Good morning, good afternoon, good evening, wherever you are. You are warmly welcome to this session. We are very excited, me and my team, to have all of you. And thanks for joining. I can see we have a very good attendees. The number is keeping increasing. Oh, it's amazing. So in our session titled Transition of Care from Pediatric to Adult Services in Inherited Blood Disorders, we have a very wonderful speakers today. And please spare your ears and your eyes to watch and listen carefully. So my name is Dr. Agnes Jonathan. I'm based in Tanzania, but I served in Gansid as a mentor for Gansid Mentorship Program, as well as I'm a member for Healthcare Providers Working Group, where I contribute all my expertise to make sure we keep the ball rolling for sickle cell and for other inherited for the sake of patients. So I'll start with the few housekeeping. And please introduce yourself, where you come from. We'll be happy to know all of you. And I'll introduce the speaker shortly. You'll be able to see all of them. And just if you have any questions around, please use the Q&A chat box to pop up your questions. And at the end of all speakers, will be able to project and say your questions and allow speakers to respond accordingly, but other speakers will be also able to respond through the chat box. We ask all of you to adhere with all housekeeping, and your microphone and your video has been disabled throughout the duration of the webinar. And we try all the best to answer all the questions, so we try to keep time. Please try to use a very respectful language. I know that is not an issue, but just to remind all of you, and do not post any unrelated material concern these topics. I know most of you would be able to be keen to look after these webinars. So don't worry, all the recording will be posted in 4 to 6 weeks. So please keep watching and follow us on our website where you'll be able to see all of you. So in today's, we have 3 big speakers with a lot of expertise of what they are doing. They're very passionate. So we have Dr. Uma Athal, will take us through bridging gaps between pediatric and adult provider for efficient transition programs. The second one is Dr. Sandra Newton, will address the psychosocial and mental health needs. It's very important. And the last one is Mr. Chad Paris, who will take us through the key experience in transition from pediatric to adult from patient perspective or patient partner. So you can see the way today's session, you'll have all the full in one plate. So I would like to start with our first speaker, Dr. Uma Athal. Is a pediatric hemato-oncologist and professor at McMaster University and McMaster Children's Hospital. Her clinical interests are pediatric leukemia and hemogranulopathy. She was a co-founder of pediatric leukemia. She was a co-founder of pediatric and adult joint lifespan hemogranulopathy clinics at McMaster University and Hamilton Health Science. She's a chair of disease-specific working group for hemogranulopathy for Ontario Newborn Screening Program and on advisory committee for the same. Uma is actively involved in global health, especially in sub-Saharan Africa. She is a consultant to various projects in sub-Saharan Africa, including sickle hemogranulopathy research in Zimbabwe and Zambia. She has received funding support from CIHR, HALT and AMP, Stroke Foundation, as well as C17 Research Network. She is currently developing tiered curriculum for healthcare providers at different levels in the care of sickle cell disease. A round of applause for Dr. Uma. Thank you, and the floor now is yours. Welcome.
Thank you so much, Dr. Jonathan, for your kind introduction. I'm told that I have only 15 minutes, so I'm going to really start now. So if we can go to the next slide. So just an outline for my presentation. I mean, we're talking about it because we have successful in getting pediatric patients to adulthood on various blood disorders. So we'll talk about the challenges of successes, overview the comprehensive care needs for all these inherited blood disorders, and then the current gaps in transition from pediatric to adult care. And then I'll briefly discuss the models of transition of care. And then if time permits, I'll talk about our lifespan clinic model of care. Next, please. So this is way before we started our joint clinic, and just a brief history of a patient where the transition didn't go as planned. So this was a patient who was um, who had transfusion-dependent beta thalassemia, was treated in the pediatric center, and then was transitioned to adult care. But the adult care was unfortunately a little bit fragmented. So he got his blood transfusions at some place and then got chelation and other thalassemia care at expert clinic. But he chose to but he had had some fallouts and continued with transfusion, but didn't continue with chelation. And then he was lost to follow up for a few months. And when he was 20 years of old, visited the emergency room with signs of heart failure. And that time it was detected that he had massive iron and hepatic cardiac iron overloads and was a very rocky course. So this is, we don't want any of such things happening to our patients, and that's why transition is very important. Next slide, please. Can we go to the, yeah. So what is transition of care? Transition of care from pediatric to adult care is a well-recognized challenge for adolescents and young adults, not just with hemoglobinopathy patients like sickle cell and thalassemia, but anybody who's got chronic illness. It's a multi-layered process. And our end goal is to ensure that the transition is as smooth as possible for all parties involved. And hence, it is important to investigate patient experience with and knowledge of transition. So I think we have a great speakers, including somebody with life, Dr. Mr. Paris with his life experience. So we'll hear about that. Next slide, please. So it also happens, a transition of care also happens at a very difficult time in an adolescent and young life. Next slide, please. Um, Before I go to the transition, I just want to give a quick overview of the inherited blood disorders, which are the hemoglobinopathies, other hemolytic anemias, hemophilia, and bleeding disorders. These are all rare conditions which are present at birth or manifest soon in early childhood and usually require multidisciplinary care for the life. It is impossible to cover all the inherited blood disorders, but what I would do is that I'm going to focus on sickle cell disease as an example. Next, please. So thalassemia and sickle cell disease are two common hemoglobinopathy disorders, which are genetic disorders. Patients with thalassemia require every 4 to 6 weeks transfusions starting very early in infancy. And if they're well transfused and manage their iron overload, they usually live a good quality of life. We just saw earlier, if we don't have a good chelation plan, then how that could be a very hazardous condition. Whereas sickle cell disease, on the other hand, if we can go to the next slide, please. So it's a sickle cell disease is a single gene defect with alteration in the beta chains. What it does is that it leads to precipitation of hemoglobin in the red cells, and the cells change the shape as shown here on the screen. The cells, rather than being round, they become sickle shape. They also become very angry and inflamed and cause inflammation of the interior of the blood vessels and attract other cells, causing what we call sickling and clogging of the blood vessels. Next, please. This clogging of the blood vessels can cause a lot of issues, including the pain and end organ damage. It also leads to red cells not surviving for normal 120 days, but instead of that, the red cells kind of can survive only 10 or 15 days and leads to anemia and hemolysis. So as I shown in the picture on the right hand side, almost every organ system in the body gets affected because of the sickling and can cause damage to these organs. Next, please. To manage these patients and to avoid the end organ effects and help the patients lead a normal life with good quality of life, we need a comprehensive care, and this is what a comprehensive care for hemoglobinopathy patients look like. We have community physicians, we have emergency room physicians, and expert outpatient care as well as inpatient care, management of their pain. So it's a multitude of problems, and they need a multitude of disciplines of care that needed. Next, please. However, we have learned a lot about the hemoglobinopathy over the years. And what we see here, the left side shows you the survival curves for patients with transfusion dependent beta thalassemias. And in 1970s, as you can see, there were v- many majority of the patients would die before the third decade. Whereas now majority of the patients live beyond the fifth or sixth decade, and now almost 100% of the patients would live with good chelation treatment. On the right hand side, what you're seeing are the survival curves of patients with thalassemia. So these last two graphs are from Jamaica, where over the years, this is an old slide, but majority of the patients are surviving. And even in the US and UK, almost 100% of the patients would survive beyond the childhood age group. Next, please. So what that has done is that good care, good understanding of the disease status and availability of the resources. Now the sickle cell disease has evolved from being a childhood disease to a chronic disease of the adulthood. And that is true for almost all of the inherited blood disorders. Next, please. So when we look at the mortality, very few children die from sickle cell disease before the age of 18 in the US and North America. Next, please. This is a recent study published in Pediatrics, and Dr. Maganan and his colleague, what they showed, it's comparison of patients with sickle cell disease from 1979 to 89, which is in the pink color, or then 1990 to 98, which is in the gray color, green color, and 1999 to 2009 in blue color, and 2010 to 2020 in the purple color. So as you can see, on the x-axis, there is a mortality rate, and on the y-axis, the age group. The mortality has tremendously reduced for patients in the early infancy. But as they approach the transition age, the red line shows the transition of time, especially in the North America. You can see that the death rate kind of keeps going up, and it peaks around 25 to 30 years of life. And why so? Next slide. Next, please. So why it is important is that because the complications of sickle cell disease accumulate with increasing age. As shown here, in infancy, we have few complications, but as the child becomes a young adult and adolescent, the severity of the disease also increases. Next, please. And here it is very nicely shown that the severity of the sickle cell disease, it's kind of goes up along the age group and then stabilize somewhere in the adulthood. So at the time of transition, it's not just that it's a transition issue, but also the disease severity for some reason changes. Next, please. So this is a good study which was recently done and published in Blood Advances by Howell et al. And what that they looked at is the transition gap. So after the last clinic visit in the pediatric care setting, if there was more than 6 months gap to be seen in the adult care setting for patients with sickle cell disease, They had an increased hospitalization visit, increased emergency room visits compared to those who were seen in the adult setting before the 2 months from the last pediatric visit. That just highlights the importance of continuity of the care from pediatric setting to the adult setting. Next, please. Transit this time, as we said, is difficult for patients with sickle cell disease because of the disease severity and other issues. But as such, adolescent period is very difficult. Those of you who have adolescent children or we have gone through that, we know that they have a lot of issues with their physical changes. They have to balance the emotional changes, their identity formation, the peer pressure or the social pressure, as well as this is also the time that they graduate from high school and they have to choose their career path. So all in all, it's a perfect storm that can cause problems during this period of time. Next, please. The transition of care also kind of creates issues. There are care related issues and there are patient related factors. From the healthcare providers, because these conditions were so far in the pediatric realms, most of the adult healthcare providers do not feel comfortable and they consider these as pediatric diseases. They may have lack of knowledge, they have inadequate of lack of experience dealing with their issues, and again, they don't have the adult comprehensive care facilities as the pediatric care providers have learned to build. Sometimes they don't have unified care for adult patients, and they may have lack of resources. On the patient side, there is a change of care culture, and we'll come to that in a bit. The care in adult side is more self-directed. Also, the patients are unfamiliar with the healthcare providers. The people that they're seeing from growing up, they suddenly see a lot of different and new people. They have lack of comprehensive care facilities. And also during this age group, they may lose medical insurance. There may be financial issues. Next, please. In hematology particularly the hemoglobinopathy, in areas where the sickle cell disease or thalassemias were not common, now it has become like a global disease. But about 10, 20 years, these were not the diseases which were commonly seen in Canada, where I practice. And so healthcare providers consider this as foreign diseases. There is unfamiliarity with the condition. There is lack of experience, lack of resources. And also there were challenges with getting chelation therapy for thalassemia patients. On the patient-related factors, m- some of the patients are immigrants, so they come from either
2 minutes.
all right, thank you. Although they come from socioeconomic conditions, language barriers, and there is also racism and stigmatization. Next, please. Um, so these are the patient-centered care versus adult-centered care, where there is nurturing, paternalistic, and parent-centered pediatric care. Whereas in the adult care, it's more informing, total autonomy. Our adult colleagues say that if you don't show for 2 visits, we won't see you again. So those are all the issues that people with who are transitioning from pediatric care to adult care face. Next, please. What is healthcare transition? This is a purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to adult-oriented healthcare system. Next one. So this is just not transfer to adult care. It's a process and not just one-time transfer. Next, please. There are there are 6 core elements of transition, right? You start at age 12 to 14 discussing what is transition and prepare them to go through the transition by making them independent in taking care of themselves. Next. There are many transition care models. One of them is like transition clinics. So people run different transition clinics, different than a pediatric clinic and an adult clinic, where adult and pediatric providers meet and then discuss the patients and help them through for maybe 2 years or 3 or 4 years. Next. Or you can have a transition care facilitator who actually helps the patient and carries them through the process of transition, starting couple of years before and following them for a couple of years afterwards. Next one. Uh, they can also have a remote or digital model where they can educate patients and help them to use on online self management skills. There would be set telephone coaching from healthcare professionals. And usually this is flexible and patient can use this on their own time. And people have used it in combination with either the transition clinics or transition facilitator. Next. There could be a primary care based model where the consultants act as consultative services, and there could be hybrid model that combines any of these combinations. Next one.
Thank you,
Uh,
Dr. Uma.
okay, thank you very much. I'll just go to the conclusion slide. So in short, what I want to say is that transition process is very difficult, but we are making a lot of progress and we are helping patients to transition smoothly. Thank you. Dr. Jonathan, we can't hear you. Maybe you're muted.
Yeah, thank you. Thank you very much, Dr. Uma, for a very, very wonderful presentation. I can see a lot of loves and different reaction from members. And people start putting the questions and comment in the Q&A. Please bear with us. We read all the questions at the end of our presentation from all speakers. So I would like to take this time to introduce Dr. Sandra Newton, who is going to address psychosocial and mental health needs. So Dr. Sandra Newton is a clinical and school psychologist living and working in the Greater Toronto Area, Ontario, Canada, and has practiced in a variety of educational, clinical, and community settings. Dr. Newton supports the MPH in Black Health Graduate Program at University of Toronto as interim director and program faculty. In her work with the Sickle Cell Awareness Group of Ontario, as a psychosocial program lead and as a member of Global Action Network for Sickle Cell and Other Inherited Blood Disorder Board, Dr. Newton can pursue longstanding interests in providing advocacy, education, and support for children, youth, and adults with sickle cell disease. A round of applause for Dr. Newton. Welcome, the floor is yours. You have 15 minutes ahead of you. Thank you.
Oh my goodness. Thank you very much, Dr. Jonathan, for that lovely intro. And I want to also thank Dr. Atale, who I follow, but by no means, pretend to replicate. Just your experience and the work that you're doing globally is so appreciated. This is just my opportunity to say thank you. So with that, I have my timer on because I know Dr. Jonathan is strict about these things. And I will share my screen with everyone. I am going to touch, lightly on some of the things you've heard about, but much more, I think, speak about just as titled, those psychosocial and mental health needs. And I try not to lean a lot on, rates and diagnoses and all of that stuff. I'm actually hoping that we can speak more to just, maybe an inside out view. What our young people are going through in tandem with getting ready for adult care. There's so much going on, and I'll do my best in the time we have just to touch on some of these things. I think they all deserve their own topic and their own time. With that, let me advance here. Let me see. Oh, good. All right. So as mentioned, adolescence is a busy time, to put it mildly. In my work, I meet very young children and I meet folks on the upper end of what we call that adolescent period, typically starting just before the teen years and going into early adulthood. Many would say that in this day and age, adolescence is actually an extended period. There was a time where things like childhood and these teen years were not treated separately or even specially. You would enter work appropriate for your age and stage. and help your family that way. But of course, with the advent of education and opportunities for youth to be engaged in that rather than in the workforce at an early age, adolescence has changed over the centuries. Currently, we've got a number of things happening. But one thing that hasn't changed perhaps a lot is the biological activity. Certainly, adolescence is a time where brains are growing and developing at high rates. There are physical changes that are very hard to miss for others that are observing, and also for the young person going through these changes. Cognitively, I mentioned the brain growth and development. This is a time of great learning. This is a time where we're starting to understand self and other. We're trying to figure out our position in society. There's a lot happening therefore cognitively. And I mentioned identity as well. And I don't suggest that identity is a independent or solitary sort of construct. There are multiple identities that young people are negotiating. It can be around their membership in their family, their social group, their racial, faith, religious, even gender, and other identities that they may be navigating. It's a time where they are starting, as I mentioned, to take on a bit more responsibility, typically, or autonomy for some of the activities in their life, but that has not been completely released for most teens. We understand instinctively that even though they may be changing in terms of their physical being, and in some ways their emotion regulation capacity, they still need that support. This is built into these transition programs, which understand that it is not something that you can do alone successfully. You do need that guidance and ushering, as you would for so many other types of activities in youth. I mentioned, just as the final point on this slide, that childhood and adolescence are key times where a number of very common and high frequency mental health conditions occur for the first time. Attention challenges, mood disorders, anxiety disorders. A number of these things tend to emerge in childhood versus later in life. Another reason that we need to appreciate, again, that inside out view, how much our youth are truly navigating to get through what looks like day-to-day life. And then, of course, chronic illness on top of that, right? This is not just about, being a teen and moving into adulthood, which nobody does, I think, with ease, although it may vary. This is now also considering what it's like to bring into this next stage of life your experience having a chronic health condition. And we're speaking now across blood disorders. Youth will typically have had a congenital condition that they're born with, in the case of something like sickle cell disease, or something acquired later in life, or later in that childhood period. So they will have different amounts of time and experience with awareness and understanding of their health and participating in tasks of caring for those health conditions. What do youth with chronic conditions like those inherited blood disorders report? Well, that there are a lot of good things about moving into this time of life. Socially, they may enjoy different relationships and status. Their interests can be pursued. They're finding other people who think and like the things they do. They're becoming aware of their own likes. And for some, they're getting a little bit more access to things they want to do outside of the home. That said, the challenges can be multiple. Academic expectations are ramping up. Relationships, as much as they can be positives, can also be a source of considerable stress. And youth are using words like stress more and more in adolescence, which can be a code or a way of describing some mental health difficulties that are more than just daily hassles, but something needing its own attention. With that, we have heard from Dr. Atale about the importance of transition for those with chronic conditions to adult care. And there are so many things embedded in that. I thought I would break them down, although I believe the audience will know. Just to appreciate that transition as a package has multiple parts. It's teaching the planning and problem solving, the appointments, the making them, the attending them, that there can be multiple ones on a given day for some youth. Being able to report on their own health condition rather than have someone else, like a caregiver, do it. Have questions of their own that they have the courage to initiate and ask of their provider. Taking medication, for some, they're starting to have more responsibility for that. But for others, they're not yet showing that maturity or readiness. So always a negotiation. And of course, recommendations, being able to follow up on those can be done with more or less success with independence and with help. Psychologically, we know from the literature that there are a number of things that youth with chronic blood disorders and inherited blood disorders in particular report. I list just a few of them here, but adjustment is a term we use just to describe, being able to truly cope in an adaptive way with the demands of living with that condition, and that those that are not having successful adjustment tend to report more of those stressors, anxiety, and mood challenges. They're experiencing the impact of stigma. Anti-Black racism has come up. Many of our racialized youth, and they do have overlap and intersection with having these inherited blood disorders, are also talking about what they experience in society as people found to have a condition, and also just as people in society. So it's very layered and very intersecting. They speak about their family relationships changing, maybe noticing what peers are doing differently, having challenges getting more of that sort of just charting one's own course. There's always that comparison to what's typical for age, when maybe that's not always the best measure of what they can do and how well they can do it. Things like fertility are emerging in adolescence, of course, negotiating that and understanding what that might involve, and being ready for those sorts of experiences. These are all things that add to the stress and just some of the challenges of moving through. Risk-taking tends to increase in this period of time, just as a part and parcel of adolescence and how we learn, but that can also set up the young person with a chronic health condition with additional risk, which is hard to negotiate or explain to peers that are not walking that path. That sense of wanting to belong is so great. For those I know in the case of sickle cell disease, I hear often about absence from school, learning challenges associated with their condition, and having those actually shift their pathways in terms of learning and pursuit of academic and even post-secondary opportunities. Uncertainty is really the word. And this is sort of that piece of stress running all the way through. What is next for me with my condition, with my being, with who I'm going to be in the world? These are all things that are reported by youth with chronic health conditions, as well as their well peers. Now, we know that when we're trying to think about care, we need to think of so many things, right? There are a number of factors that vary within a chronic condition and across chronic health conditions. I mentioned here just a few that we want to consider when we're understanding risk for psychosocial concerns, and also the kinds of support that a transition program might anticipate. Thinking about the severity of the disease at different stages. Dr. Atale mentioned that in her talk, that it can change over time. How well this person learns and can take up the kind of program on offer, how they prefer to receive things. This is a time that we're trying to incorporate preferences for how care is received more and more, because that tends to increase the likelihood of sticking with the regime for young people in particular. We need to be mindful as well of the many steps that they may encounter just around their specific condition, their treatment, which may vary from someone else with the same health condition, how complex those steps are, and how effective they are. At least from a youth point of view. I've just shared here a few of the elements from the Hospital for Sick Children's program that Bradley and others reported about, just in terms of modules that are part of their transition module and that have relevance around the psychosocial needs of youth, thinking about that future question and that uncertainty. Sexual health, talking about that maybe for the first time in conjunction with disease, what it means to live healthily even when you have a health condition, nutritionally, otherwise. And then, of course, managing disease, and self-management is what we call it, because you are, as the young person, perhaps for the first time coming forward as an agent in that management, not being done for you, but with you. So we really want to build those things. I would say as well that we've learned that successful transition programs are not just focused on youth, but also include parent elements, really take into consideration the capacity that young person has. And I include in that their learning, their maturity, right? To really take in what's expected and maybe follow those steps in a way that makes sense for them. Perhaps it's conceptualized as a 5-step module, but maybe that person needs 8 or 10, right? Or maybe fewer, just really tailoring things as much as we can. We need to also be able to do what we call troubleshooting for those who are not able to make the appointments, coping well with the expectations, moving through the transition program as scheduled. How quickly are we getting to solutions with them? How collaborative are we? I think that's an important word. that brings in the young person more. We realize within psychology and some of the interventions around behavior, et cetera, that when you collaborate with young people, and that means including their ideas and solutions around barriers and overcoming them, success is more assured. I just wanted to share that here in Ontario, Canada, where I live and work, we have had the advent of health quality standards by our government to talk about the ways that healthcare can be distributed in an equitable way for folks with sickle cell disease. I pulled just a couple of the statements that I think share our topic today. That transition needs to have a number of elements. As I mentioned, incorporate caregivers, right? Keep providing support until the young person confirms that the transition is complete. What an important piece of wording to say that we need to check in and measure how we're doing from the young person's perspective always. That when it comes to psychosocial pieces, assessment is super important, which means we're asking the question and we're measuring how we're doing. We're not sort of waiting on self-reports. I think if you've spoken with a teen lately and you've asked them how things are going, they'll say fine. But we want to actually measure it, and questionnaires and other tools are excellent ways of doing that. I'm personally interested in health-related quality of life and having that self-assessment by the young person. With those reports, we act on them. We don't just collect the assessments. We absolutely include them in how we do the work. I would say that as much as there is a lot done in the transition to adult care space, and a lot of models available, as you've heard. When I think about a psychosocial perspective, there are a number of things that I think we have opportunities around. Of course, we want. Thank you. Globally, we want to make sure that everyone has access to this. And of course, in North America and the West, we may have more funding dedicated to making sure transition is successful by way of programs and personnel. But we need this everywhere because this is happening globally and simultaneously. We need to do well across the board. I mentioned measurement and evaluation. I will just maybe focus on a couple of points with time being short, that resiliency needs to be embedded. So I showed you some sample topics. I'm personally hoping that we can have much more of a focus on mental health. Sometimes it's the first time that we're talking about the risk in adolescence and as a result of pressures associated with healthcare and health conditions about the risk for things like depression and mood challenges. That stress is real. We want to validate that and provide some absolute concrete tools for moving through that and adapting successfully. I believe we need to teach it and not simply assume that it will come to a young person. That deliberate teaching is super important. We need to have a number of ways that we try to offer that teaching. Obviously, in-person sessions with a health psychologist or someone providing that transition counseling is great, but we need to be open to virtual and independent or self-paced for those youth that can do that. Again, we're listening to what they want and we're moving with them through this because we know it's so important that they have that access. I know I raced through that a little bit. Maybe I'll just spend a moment more. I think I have 30 seconds more. So again, not wanting to miss the opportunity to speak about the importance of tailored approaches. I will even say that in Ontario, when we talk about racialized youth, Black youth, youth of other ethnic backgrounds, they are telling us more and more that they would value practitioners and providers that look like them, who may not share their disease status, but truly understand that intersection of race and dealing with healthcare and all of the very loaded things that have come with that, so that it becomes a more safe and welcoming space that they're more likely to want to engage with in the future. So I will pause there and just say thank you for your attention.
Wow, thank you. Thank you very much, Dr. Newton, for a very wonderful and informative discussion. I can see a lot of reaction going on. Clapping, love hearts. This is so amazing. And we really need in transition the psychosocial component, which is very, very forgotten area. And now it's an emerging area to be embedded as a holistic approach. So thank you so much. I can see another questions on the Q&A. Please, the previous two speakers, have a look at the chart Q&A if you can start responding to some of the questions as introducing the last speaker for today's session. So the last one is Mr. Perez, who will take us through the key experience in transition from pediatric to adult care from patient perspective. So he is performance coach, analytical psychotherapist, and speaker with a dual focus on individual and group psychotherapy and advanced corporate training. He's a professor of communication and soft skills at BCA College and a certified trainer for TUV Australia Hellas, delivering seminar in leadership, human behavior, and team dynamics. With a BSc and MSc in architecture and a diploma in adult education, an EAP accredited diploma in analytical psychotherapy, and the ICF coaching certification, he brings an interdisciplinary approach to personal and professional development. His work blends Jungian psychology with practical leadership tools, fostering meaningful presence and sustainable transformation, both in therapy rooms and corporate space. So a round of applause for Professor Paris. The floor is yours. You have 15 minutes to time. Thank you. You may start.
Thank you. And first of all, I'd like to thank you for inviting me here and giving me some space to talk, first of all, as a patient of thalassemia, among so exciting colleagues, I would say. So I'm only going to show you 4 slides, so bear with me. It's going to be quick, and I'll try to use some storytelling. If we can switch to the first slide, please. Okay, I give you some background to know the foundations of what we are about to speak of, a professional one and a clinical one, just to have some things in mind. In order for me to explain you, to give you some access to my experience as a patient moving from childcare to adult care facility, I want you to imagine that here in Athens of Greece, we have a major childcare hospital that treats people with blood disorders, thalassemia patients, etc. It's the biggest hospital here in Athens for these issues, and it's part of an even bigger facility that has many departments for childcare, like cardiologists, have an enormous center for children with cancer, etc., etc. And I want you to imagine also that in this center, we have about 600 to 700 patients that need blood monthly, on a monthly basis. 600 people needing blood, and the other facilities of the hospital needing blood, because we are going to talk about blood scarcity later on. So in this major hospital, you go there when you are born with a blood disorder, and they keep you there, and they offer you many, let's say, some guidance. Okay, I listened carefully to the transitioning steps of Dr. Rumathel, not even close to that. So you reach this point and you stay there being treated. You reach the adulthood, but then you want to go to someplace else, an adult care facility. And you cannot go there because of bureaucracy and because imagine something like there are no available positions in other hospitals. The other hospitals have about 100, 150 positions for thalassemia people or blood disorder people. So from the one hand, the hospital tells you that you reached adulthood and you should go to another hospital, but on the other hand, you cannot do that. And one more thing about the foundations of the 3 stories I'm going to speak about. The most critical issue is that when I was in this hospital, this major pediatric one, I tried to, if something happened to me, an emergency, or I just needed some exams, like I need to see the cardiologist. I cannot move to the building next door because they only treated children. So I had to stay inside there, but I couldn't use any facility other than the one treating beta thalassemia people, with only 6 doctors, 6 to 7 doctors with pediatric expertise. So if we can change to the second slide. Now, I'm going to talk about 3 stories. one regarding a health issue. If we can change the slide now, it will be amazing. So the first story is how I managed as a patient to relocate myself and reach an adult care facility. And this came out of a crisis issue because I was being treated for many years with, for 6 years actually, with some oral treatment, a specific drug we use for iron chelation. And this was an experimental drug at that point, and everything went fine. I finally got rid of the needle, and I had the pleasure of not, of only taking oral treatment. After 6 years, where nothing happened, I started getting dizzy. I started fainting. I almost fainted on the street, and I reached my doctors. I went to this major hospital, childcare facility hospital. And the only thing that they told me and they could do is measure my hemoglobin, where it was about 20 to 21 points. These incidents happened again. And over the period of 2 years, I had emergency transfusions while I reached 21, 22 hemoglobin points. And in the end, I was treated in an emergency room for 3 times. So I will say that at least I think 2 times I nearly died. And the issue was that when I was having this emergency, I couldn't move to the next building to do some exams because although it was an emergency, I was a child under the law. I was an adult, but I was at a child care facility with no access and no possibility of leaving this facility. So this is the reality here in Athens, and it still is. And to finish my story, thankfully, when I was in the emergency room, they did some gastroscopy and colonoscopy in me and found that I was blood hemorrhaging. I was losing blood. I changed the treatment, and thanks to Mrs. Delikou, she was a speaker previously, the head of the department in the hospital I'm being treated now, I was saved. The second story, if we can change slides now, would be amazing, thank you. I'm going to talk about a story of blood and memes. So the bureaucracy here in Athens, in Greece, is a big monster. I suppose that you have the same issues in your countries, I can only suppose, but I'm going to talk to you about an incident to experience my reality and the reality of many patients like me. During the summer seasons or the extended vacation, like Christmas or Easter, things we have here, the Greece experiences blood scarcity. We don't have blood. And it's due to the mechanism of the government, etc., but the blood center of the hospital I was talking to you about calls us and says something like, Paris, I know you need 2 vials of blood, 2 bags of blood every 12 days, approximately. I can only give you 1, maybe I can give you 1, but I have a suggestion for you. If you can bring me at least one of your friend, colleague, or a relative to donate blood for you, then I will give you 2 bags of blood. It's something like a blackmail, and it's something we are experiencing for decades now. But it's okay, I understand. Many people, 600 people needing blood each month, and all the other departments of the hospital with surgeries, etc. Okay, I understand. So I start calling for favors, and I bring 3 people, not 1, 3 people. I convince them to leave their jobs, come to the specific hospital at a specific time to donate blood for me and for all the other people, of course. Not 1 person, 3 people. So After that, the blood center calls me and says something like, Paris, I understand that you brought us 3 people, but not only 1, 3, but I can't give you blood. I can only give you 1 bag eventually. So I understand. It's an emergency. I want to help. The last but not least of the things I want to tell you about is that when I reached the clinic, the pediatric clinic I was on, with the mentality of a child, if you like, I was faced with a conversation from co-patients of mine saying something like, my friends called me and they asked me if I needed blood to donate for me. And I told them, no, do not come, because if you donate blood for us, the government wins. So this is the mentality we face here. And I don't know if it's searching for identity, like Dr. Sandra Newton said. And I talked about stressors, and I heard about stressors and many other things like that. But imagine all of these in a context like that. So if we can switch to the last slide. I hope I have 2 more minutes and I'm concluding. I have created something like meme here. The last part of the experiences of transitioning is one of psychological issues. When one of my favorite stories to understand what a child is experiencing here in Athens, in Greece in general, is that I was baptized inside medical container. When I was born and the doctors saw that something was happening, I had a health issue in 1988. They didn't have much knowledge then, and they did whatever they could. But there was a priest there that when he saw me, he said something like that I'm possessed and something is happening to me. So he suggested I was baptized. And my parents, they were really frightened and they did everything they can so they did that also. 14 years later, I experienced my anxiety of how long I'm going to live, what's the expectancy. And I asked one of the best doctors there, the most knowledgeable at the time, and she told me that I was going to live for 10 years more, reaching the age of 25. The only reason I'm discussing these issues is to understand the mentality that a person like me could have without proper training, without facilitators like Dr. Ruma Feld mentioned, zero guidance. The only guidance I was thankful to have was from my parents. And this, for me, is the most critical issue in dealing with the whole treatment and disease thing. Last but not least, and I conclude my presentation with this, is I transitioned to the adult care facility 3 years ago. And while I was at this major hospital that I was talking about, I remember never seeing a person over the age of 50. And you can imagine how this reflected inside of me. And I was wondering if something's wrong. When I transitioned to this adult care facility, I saw people, most of the people being over the age of 50. And I saw for the first time in my life somebody being over 70. And I leave you with a question. Based on all the things that I've told you about the situation here happening, is it random? Is it a random fact that I never saw somebody over the age of 50 while I was being in the childcare facility? Or it's somehow connected with all the
1 minute.
With all the access I could have from the other departments or not. This is the end of my presentation. Thank you once again for the chance. If you have questions, I'd be glad to answer.
Thank you so much, Professor Paris, and for your very, very informative and educative, and actually for having the experience from a live one is really, really impressive. And I can see a lot of comments, like people say your story related to them. People were closely follow up, and you know, I know people has a lot of questions. Again, a lot of reaction, different reaction, hearts, clapping hands. Oh my gosh, the reaction is so amazing. So we have left with 5 minutes, and we have a number of questions, but I was trying to see the questions related to each other. So maybe we'll start with the last speaker, Professor Paris. In your own experience, what does an ideal transitional pathway look like from clinical coordination and mental health support, patient empowerment? You heard from Professor Uma, Dr. Newton, and now you. What is ideal transition pathway look like on your own experience?
Honestly, I think that the psychology and the handling of the moods, like Dr. Sandra Newton mentioned, and everything around the psychology and how somebody must have a facilitator, a mentor, or a guide. If you don't have that, you can find people, you know, being scared of transitioning. I have seen this. People not wanting, having the ability to transition to a hospital that will expand their life expectancy. And they cannot move. They feel like family, even in the previous hospital, even though that they know it will lead them to living less years. So for me, this is the most important. And of course, hopefully all the bureaucracy and, you know, the logistics are solved.
Okay, thank you so much. I can see a lot of questions focus on health equity, especially on the access. And in most of sub-Saharan Africa, where we have poor access on transit from pediatric to adults, like people asking, it's kind of different from where you are, Dr. Newton, where you are, Professor Umal. For them, it's very hard to access those facilities. So just a single question to all of you, and you can answer as from your experience point of view. When taking consideration transition from pediatric to adults, which involve clinical, psychosocial, and lived experience dimension, what is the most single important factor that determine whether a young person successful transition into adult service? Just a single important factor. I know there's a lot of factor, but just point out one single factors. Over to you, Dr. Newton.
You only give me the easy questions. It's very hard for me to distill something down to a single factor. Imagine if there was just one thing that we needed to do to make everything else go well. But I'll tell you what came to mind quickly, and it's relationship, right? And I think that that is definitely a word we can explode. It's all kinds of relationships. The one with self, that confidence in one's ability to navigate these challenging situations and have them be rich and positive. Having caregivers and others who remain in your circle and want to support you forward with your goals. And of course, those ones with healthcare that you're navigating your whole life long. Relationship building skills and relationship maintenance skills and the ability to receive from relationships. That's what I would say.
So relationship. Professor Umal, in 1 minute, what's a single most important factor from your end?
Thank you very much. First of all, thank you so much to Dr. Newton and Professor Paris. Excellent presentations. From where I sit, I think I would ask for resources. Everything, like even developing relationship, getting blood products. There's all kind of ultimately land on resources. If I have more resources, I can spend more time with the patients. I can develop the relationship. I can teach them the life skills. Or if I have a psychologist, great psychiatrist like Dr. Newton, maybe they can help. But not all of us have. Even I read a comment that how come province-wide we don't get everything the same in within Canada as well. Again, even within one province, not all institutions have everything. So I think resources equity, which allows everyone to kind of learn, grow, and develop is very important. Thank you.
Thank you so much. All in all, we can say it's a holistic approach, right? Where we can have all multidisciplinary. So everybody play a crucial role in make sure that this is very, very important and carried it out through and successful. Please, our host, can you confirm if we can have like more 2 minutes? We have a very, very burning question to Dr. Newton. From your experience, especially when you have you come across the child with sickle cell and the ADH?
Yeah.
Yes, what is your experience on managing that patient? I think that's the very popping questions. Everybody is exciting to hear your experience. Thank you.
Sure. I think we're speaking about ADHD for short and attention deficit hyperactivity disorder in full. And this is a condition, again, something that is first identified in childhood that affects the way that one sustains attention and reduces the impact of distractible things outside of themselves to get tasks done. It has to be something that's interfering with the child's performance. And, you know, with sickle cell disease being a condition that does affect brain and cognitive functioning, there are a subset of youth that are going to qualify for that. So in schools, I do see a range of children without sickle cell that do have attention challenges. The piece that I would say very much in brief is that we need to be aware of the risk and not explain away attention challenges as just part of maybe the fatigue of the anemic state or some other factor, even absenteeism. We need to be screening our youth, not just for their physical health, but finding out. And I think that our pediatricians do a very good job of this, asking about school performance, looking at report cards. I know that they're very much invested in their success and keeping that school engagement going in early years. This kind of screening, asking parents, asking teachers about attention in particular, can lend itself to appropriate diagnosis and treatment if warranted, or at least increasing supports, which we call accommodations, in the classroom to help children that struggle with focus and attention. So I think there are a lot of great treatments out there. It's well studied, and there are both behavioral and medicinal interventions depending on how severe it is and the age of the child. It does occur. I think the most important thing is to understand that it can be a part of the life of a young person with sickle cell disease, and to then move accordingly from there. So I'm always about measuring it and asking the question.
Okay, thank you so much. And I've given go ahead up to 25 minutes. So I know we still have some minutes, but please, if you want to listen, I know this is a very interesting session. Please stay with us as Dr. Newton also is going to answer the second question. So from your experience, and when we talk on a Black population from Sub-Saharan Africa, where we have a limited resources, right? What are some practical ways to monitor mental health and well-being of youth during the transitional process? What is your comment?
And I think practical is important. We've already heard that, and I loved Dr. Atale's reference to resources. Without those, what do you have? I do know that we're very resourceful people, but we've done a lot with not enough for a long time, and we would do better if we had steady resourcing, financial, person-wise, all of that. So what do I think about practical ways of monitoring? I think that we have a number of great means of measuring. I keep mentioning it, but I think without asking the question and without using whether it's a scale, a questionnaire, an interview, and prioritizing gathering that information, we can't know what's going on with young people. Mental health conditions are the sorts of things that you can't see from outside. Someone said to me once, I wish they had a rash, you know? Because then people would understand what I was going through. So because we do have some sorts of mental health concerns that you can see, we call them externalizing disorders. The behavior is evident. But for other things, especially mood and anxiety, where I feel youth in particular, in general, and those with chronic health conditions in particular might have more risk for, we can use questionnaires, and they are very youth appropriate. Their language level is reasonable. Those are things that are obtainable free online. Those are not licensed products. There's one called the PHQ, another, the GAD. These are standard mood and anxiety screeners that have normative data or comparative data for people in their teens. We can see how that person is describing their symptoms, how many they have, and how so much they interfere. That's always the question. And I think that those are great things. I think making it part of every checkup where we're asking, and then also giving the way of indicating it on a questionnaire, which can be a little easier than answering verbally, we do that. And I think as much as health maintenance is part of every appointment, just for physical health follow-up, there is some discussion of tools, recommendations. There are so many great apps and other resources like that youth can take advantage of that may not be sickle cell or blood disorder specific, but are still transferable to just realities of being a young person dealing with much. And they teach adaptive skills and they encourage practice. So I think that those are some ways. Let's take advantage of what is out there, free and available, public domain, and let's make sure that we're letting folks know about it and making referrals where we need to. If it's not possible within our center because of resources, sometimes it's literature. Sometimes it's peers. Sometimes it's other more virtual ways of accessing care. I know I love to share videos with youth because they enjoy them, and that's another way of communicating great information. Thank you.
Thank you very much. I love HQ9 actually, especially on the screening for psychosocial on adolescents. So yes, that is freely and we
Quality
can
of life.
leverage, especially from Sub-Saharan Africa. So maybe the last question before I turn the table to the host from Professor Uma, from your experience working in Zimbabwe and Zambia, can you tell us in just 30 seconds, how do we apply the transitional model in low and middle income countries, especially in low income countries, Sub-Saharan Africa? Just 30 seconds.
You're on mute, Dr. Attal. Just very, very brief. Thank you very much.
Thank you. I think the transition models are contextual, what you have and what best you can do with what you have, because there is no perfect model. I mean, two people can make the process of transition work the best if that is all you have. But just being aware about the needs. And if I may take this opportunity and also kind of, there was a very good question in the question answer this thing that what can the family and friends do to help the adolescent pass through? I think what I tell my families and patients is we are a team here. It's not you and us, it's we together moving this whole thing forward, right? So including the family and friends, understanding and also that the families have lot, staying connected, connection, which Dr. Newton said. It's also the period when I think the adolescents alienate their parents, they counter, they kind of question their authority, and so it is hard for the parents to kind of understand them. But I would say listen to them, validate their concerns, because I had just had recently a patient admitted where the family didn't feel that he had pain when he was scoring pain of 7 and 8. So I think validating that, being with them, listening to them would be very important. So thank you.
Thank you.
Thank you for inviting.
Yes, thank you so much, our wonderful speakers, for a wonderful presentation, and thanks for our attendees, all participants, to stay alive. We had several numbers of attendees online, and we want to appreciate your time. And we hope these materials will be useful to our setting and to our clinical practice, just to help our patients so we can reduce the mortality and morbidity from our patients. So thank you so much. And I hope we're going to have a follow-up discussion one day and a tailored presentation, especially to tackle Sub-Saharan Africa. So thank you so much. Over to you, our host.
Thank you very
Thank you.
much, Dr.
Thank you very much.
Agnes, and thank you very much to our wonderful speakers. For those that are still here, I want to remind everybody that our day 2 of the Congress is starting tomorrow at 7 a.m. EST, bright and early for those in the, I guess, the EST region, and we'll have another round of incredible presentations. Also expect an email from us for an end of day evaluation, and for those that might have still completing this session evaluation, please do so as well. Thank you very much.
Thank you.
Thank you. Bye-bye.
Thank you very much. Bye.